So now we're going to demonstrate a vasodilator challenge. This is performed in patients with group 1 PAH, especially idiopathic, familial or drug-induced. The idea behind it is that those patients who are vasoreactive, i.e. their mean pulmonary artery pressure falls below 40 millimeters of mercury with a drop of 10 millimeters of mercury, are considered responsive, will have a better long-term outcome to the use of calcium antagonists. There are various drug regimes that can be used to test for vasoresponsivity. We use adenosine here, starting at 50 micrograms per kilo per minute through a peripheral cannula and increasing every 2 minutes by 50 micrograms. Alternative agents are intravenous epoprostenol, inhaled iloprost, or inhaled nitric oxide at 10 parts per million. We have connected the adenosine to the patient's left arm cannula, and we will now perform a pulmonary artery pressure prior to commencement, normal respiration.
Okay, starting adenosine.
And now we will start the adenosine.
Starting 120 mils per hour.
Whilst the adenosine is infusing, we watch the trace, we look at the heart rate. Adenosine can cause heart block, so we watch the ECG rhythm, and we also look at the pulmonary artery trace. As mentioned, a positive responder is someone whose mean pulmonary artery pressure falls below 40 with an absolute drop of 10 millimeters of mercury whilst preserving cardiac output. After 2 minutes, we increase by 50 micrograms per kilo per minute. We do this up to a maximum of 250 micrograms per kilo per minute, or patient tolerance. We then measure the pulmonary artery and the wedge trace at the end of the procedure. Okay, we've now reached the 2-minute mark, so we're going to increase the infusion to 100 micrograms per kilo per minute.
140 mils per hour. Starting.
We have now reached 200 micrograms per kilo per minute of adenosine. The patient's starting to develop side effects of this dose, so we'll cease the infusion there and we'll take the pulmonary artery pressure trace and the mean pulmonary artery pressure and another wedge. As you can see, there's been no drop in the pulmonary artery pressure tracing, and therefore this patient is a non-vasoreactive patient.